Ladies and gentlemen, my name is Dr. Moiz Adamji and I'm an emergency physician. Today we're going to talk about congestive heart failure, the out heart, which is still fighting. This presentation is a courtesy of Dr. Dipali, and I was her facilitator at that particular time when she presented this, and I revamped it a bit so that I can present it to you guys. This is our outline. So let's start with heart failure. What is heart failure? Heart failure is 3 points, right? There is either a structure or function problem, which results into decreased cardiac output and increased cardiac pressures that ultimately results into the signs and symptoms that we commonly know of heart failure. Now, when it comes to heart failure, it could be chronic or it could be acute. If it's acute and you knew about that the patient had heart failure already, then that's acute decompensated heart failure. But if you did not know about it, then that's de novo or a new heart failure. Now, pathophysiology is quite interesting. It starts with the insult that maybe you had a myocardial infarction. So ultimately, your cardiac left ventricular function decreased, and this results into increased pulmonary capillary pressure, because that's the amount of pressure required to overcome the blood going to the lungs. Now, when the pressure of the pulmonary capillaries increase, it results into leakage of that fluid inside the blood into the alveoli and causing pulmonary edema, and finally hypoxia. When a patient is in a state of hypoxia, this is what will happen. The patient will become anxious, increase catecholamines, increase stroke volume and BP to maintain that cardiac output. Initially, the heart will be able to sustain this, but later it will have stress on the wall and it will start stretching and become dilated. And when this happens, when the supply is less than the demand, it results into myocardial ischemia and the whole cycle repeats itself. Now, classification wise, you can read this chapter part on your own, you can screenshot it, but most commonly there are two types. You have something whereby a sympathetic drive has increased and you have hypertension, you have pulmonary edema, and you have heart failure. This is called sympathetic crash acute pulmonary edema, which is also known as SCAPE. And then there is the overload form of heart failure, whereby acute on chronic, someone did not take their medications, so they now are overloaded, and you have to just give them furosemide, and that's it. The other form of heart failure would be cardiogenic shock. So this happens most commonly in myocardial infarction, like anterior wall MI, whereby your heart is so weak that it cannot produce that cardiac output, and therefore you go into cardiogenic shock. So this is hypotension with heart failure and poor contractility. There are other ways of classifying heart failure, which is systolic and diastolic. When you know about systolic, it's contraction problem. When diastolic, it's a relaxation problem. So that's how you can classify systolic to diastolic. When it comes to echo definition of heart failure, ejection fraction, if it is more than 50%, that's preserved heart failure. If it's less than 40%, that is reduced EF. And sometimes something when it's in the middle, it could be mid-range EF heart failure. Now, why is this important to know? Treatment differs in some aspects. For example, elevated filling pressures without heart disease can be because of severe high hypertension or kidney failure. And non-cardiogenic pulmonary edema, whereby the filling pressures are normal. So, for example, in ARDS patients. So, importantly, every heart failure patient, we know that as soon as you see them, you will know these guys are gasping for air, like they are really gasping for air. That's how you know this patient is a heart failure patient. And because fluid is in the lungs, they're like doing like as if they're drowning, and you can see that. So first thing is ABCD, airway, breathing, circulation, whereby in airway, you're going to talk to the patient. Most of them will talk to you unless they present unconscious. So airway will be patent and protectant. The problem here will be in the breathing, and if there is cardiogenic shock, then a circulation problem as well. So in breathing is where you're going to intervene. You're going to give oxygen. You might start with a non-rebreather. If there's a ventilation problem as well, then you might want to give BiPAP. But BiPAP is a solid yes for me. Even before the patient if patient comes in, even if he's in mild heart failure, I give BiPAP, and BiPAP sometimes is enough. Without even furosemide, without even nitroglycerin, BiPAP will help your patient, because what does it do? That bronchospasms that the patient is getting because of pulmonary edema will be relieved. The excess amount of fluids from the alveoli will be removed, okay, because of the excess pressure that you're giving by a CPAP, with the PEEP, okay, and you're going to improve the oxygenation as well. And if they're getting tired, you're helping them with that as well. So one thing about BiPAP is there's a score called HARCORE score, and this score is predicting the failure of your non-invasive. So you can use that score to know whether you have to be ready for intubation or not. But me, whenever I'm using non-invasive ventilation, I'm always ready for intubation. So oxygen, IV access, and cardiac monitor is very important in your first 5 minutes of arrival of the patient. Now, clinical evaluation question aims to answer 3 critical questions. The first one, is it a heart failure? Okay, if it's heart failure, then is it a left-sided heart failure, right-sided heart failure, or both? What is the underlying cause to the heart failure? And what precipitated the decompensation? These 3 questions, like a detective, you're going to ask, and you'll find out the cause. Now, key historical features is obviously, like if you have chest pain in one case, history of CCF, that's obvious that, okay, this is heart failure. Exercise tolerance worse than usual. So maybe if someone was walking down the stairs but now cannot, or someone was lying flat but now cannot, those are also signs and symptoms. Increased edema. That's so common that you see increased edema, people, first thing they think is heart failure, but it could be a lot of different causes. Dyspnea or syncope is also low cardiac output. A forward failure of the heart can cause dizziness and syncope. Orthopnea is a classic, that someone was using a pillow, maybe a heart failure patient was using 2 pillows, now they're using 3 to 4 pillows, or they're sitting upright only. Paroxysmal nocturnal dyspnea is because of that sudden bronchospasm that they feel. So they need to gasp for air and they wake up at night suddenly. That's what it's called. Now, obviously, this is a cartoonic information of left-sided heart failure and right-sided. I'm going to make it simple for you. In the left-sided heart failure, the venous return from the lung is compromised, and therefore this failure leads to pulmonary congestion and pressure. While the right-sided heart failure, venous return from the body organs, failure to lead to venous congestion of body organs. So you will have that lower limb edema, ascites, hepatic congestion is what is right side failure, while the left side will more be pulmonary with dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. And that's classic teaching from medical school. Now, Firmingham criteria is also important. You need to have a presence of 2 major criteria, or 1 major and 2 minor, or you might have all the 5 minor and still call it heart failure. All right, so major criteria, you have S3 gallop, okay, that's 99% specific. Hepatojugular reflex, you press on the liver and you see the JVP rise. Lung crepitations. So Firmingham's criteria for diagnosis: presence of 2 major criteria or 1 major and 2 minor criteria. 1 major criteria, S3 gallop, 99% specific. Hepatojugular reflex, lung crepitation, cardiomegaly, dilated or hypertrophic, and neck vein distensions. Minor criteria, as you can see here. Now remember this, that nowadays we can see a lot of things on ultrasound. So you can, instead of hearing the lung crepitations, you can see them as B lines. Cardiomegaly, you can see them on echo. Neck vein distension, you can see the JVP and see the neck vein distension. Okay, and S3 gallops and murmurs and all that, you can also see them on echo nowadays. Possible causes and differential diagnosis. Ischemic causes, obviously myocardial infarction. Chronic coronary ischemia, someone had multiple coronary vessel disease and now has coronary ischemia. Non-ischemic causes can be idiopathic. Sometimes the heart failure cause is not known. It could be hypertensive heart disease, meaning a patient had long-standing hypertension, myocarditis. All these causes can be read, and you can think about them in your diagnosis. This is a classic way of classifying New York Heart Association classification of heart failure. Classic 1, mild to severe. And class 1 is no limitations to daily activities, while class 4 is someone who is discomfort even at rest. So in between, you can categorize. For emergency physicians, you will obviously get someone in class 4 rather than class 2 or class 3. Okay, so life-threatening differentials all may be present with dyspnea, tachycardia, and elevated JVP. Difference in treatment for these etiologies can be deadly if misdiagnosed. So basically, here I'm talking about differentials of chest pain, for example. So if you have chest pain, you should be thinking about aortic dissection, you should be thinking about pulmonary embolism, you should be thinking about cardiac tamponade and other key things that can kill your patient, not just heart failure that can cause chest pain as well. Differential diagnosis of any dyspnea can be these ones. Any cause of edema or fluid overload can be these ones: renal failure, hepatic failure, low protein, or lymphatic disease. Yeah? Your investigations, 80% of the time, your history and physical examination will give you the diagnosis. But you can obviously support your diagnosis with investigations. Okay? And studies have shown 80% confidence of diagnosis of acute heart failure is the clinical gestalt, meaning you as a clinician, and outperforms ED diagnostic tests. However, clinical gestalts may be only 50% accurate in primary care settings. So this is more applicable in tertiary care settings, not in primary or urgent care settings. Obviously, now let's talk about why we do what we do. CBC, you're ruling out anemia, okay? Renals, obviously, renal failure causing heart failure. Electrolytes, in severe congestive cardiac failure, some people are using furosemide for a long time, so hyponatremia is a problem, hypokalemia is an issue. Cardiac markers to rule out ischemia like troponin, CKMB. Thyroid function tests, remember that they can have a high output cardiac failure because of that. Bedside ultrasound is what is very unique for emergency physicians, because we can rule out so many things just by putting an echo probe or an abdominal probe, looking at fluid around the heart, tamponade. You can evaluate for right heart strain, so meaning if your right ventricle is bigger compared to the left ventricle, you can start thinking about right-sided heart failure. Evaluate for obvious valvular disease, evaluate for the gross LV functions and contractility, and evaluate for wall motion abnormalities, suggesting myocardial infarction. So, do you have pulmonary congestion? Yes, B lines is what you're going to look at. Are there any signs of volume? IVC, is it collapsing? Is it big? Is the left ventricle ejection fraction low or normal? These all can be answered by your bedside ultrasound. Now, obviously, this is blue protocol, which says that if you have more than 2 B lines in more than 3 zones on one side, and if both zones have something like this, then you can talk about pulmonary edema. Right? Now, here is the protocol. Let's say you have the B lines. Yes, heart failure likely. LVF is more than 50%, preserved EF. If it's less than 50%, then reduce EF. If let's say your B lines are there, but your IVC is more than 2 centimeters with less than 50% collapse, yes, then you look for evidence of acute RV strain. No, if this IVC is not more than 2 centimeters, like it's collapsing, then you can do pro-BNP to see maybe it is heart failure, but it's not yet in the overloading stage. Cardiac testing, obviously ECG is the best, and it will reveal ischemia, arrhythmias, and hypertrophy. Imaging, X-ray you can do, but nowadays ultrasound is as good as X-ray. If you do it, you see B lines, you know that this could be pulmonary edema, and you can rule out other things like pleural effusion. Yeah, and the heart as well, you can check from there. So this is B lines on the left, and this is the X-ray showing congestions or curly B lines. And bedside ultrasound, actually is outperforming chest X-ray nowadays. It's portable, it's reliable, it can be repeated, and you can monitor the progress of your patient while you're treating them. So imagine patient A comes to me and I have a patient with difficulty breathing. I check B lines day 1, they are a lot. Day 2, I have evidence of graphical evidence of seeing my patient improve instead of doing chest X-ray and exposing them to radiation. B, natriuretic peptides. These are done when you're not sure about heart failure. When you have a lot of different differential diagnosis and you don't know whether it's heart failure or not, you can do this. Now, these are some of the cut points. Like if you're doing BNP or N-proBNP, these are the cut points that you should be looking at, and it will help you make a decision of whether this is heart failure or not. The management. Obviously, management is supportive. You're giving oxygen, you're restoring the circulatory status, decreasing preload, decreasing afterload, increasing coronary perfusion. Identify and treat the underlying cause of the heart failure, which is very important. Now, obviously, there are 4 clinical profiles. We have on one side congestion and the other side hypoperfusion. You have a person who is warm and dry. This is a normal person. Okay. Then you have a person who is warm, meaning there is no circulation issue, but is wet, meaning congested. Then we have the cold and wet, meaning these are cardiogenic shock patients. And then we might even have the cold and dry. These are still cardiogenic shock patients, but they have not gone into overloading symptoms. Now, this is our EMAT algorithm, which explains clearly that you get a heart failure patient, you recognize them by signs and symptoms. You did your ABCD, airway secure and maintain if it was not patent and protected. Breathing upright 45 degrees. SpO2 less than 95, give oxygen. If not improving, go to non-invasive. Circulation, insert 2 large bore IV lines and you're doing these baseline investigations. Assess and document GCS because low GCS means perfusion to the brain is not good. Expose and assess the patient, obtain ECG and bedside echo to check for wall motion abnormalities, effusion and so forth. Now, every part of the treatment is there, like warm and dry. These are the patients who are hypertensive, meaning SBP, which is systolic blood pressure more than 140. Administer a vasodilator. This is nitroglycerin, but before the ECG. After the ECG, sorry. So ECG, if it rules out inferior wall MI, then you can give nitroglycerin because nitroglycerin decreases preload and inferior wall MI is dependent on preload, which most of the times inferior wall MI extends to the right side or posterior, and therefore you need to rule that out before. It's not an absolute contraindication that if it's inferior wall MI, you cannot give nitrate, but why would you want to make things worse in the first place? So you can nitroglycerin or hydralazine, whichever you have, and you want to decrease the MAP. Okay, so you want to, let's say if you were at 180, you're decreasing by 25%. But in this case, your target, you should be reaching 140 over 90. Less than that is okay. Diuretics comes later. Why? Because you want to first increase the coronary perfusion and the renal perfusion. That's when your diuretics will work better. Because with a low renal perfusion, your diuretics won't work. And hence, it is not worth it. So first start with nitrates, step up nitrates, and then furosemide. That's my treatment for a sympathetic crash, acute pulmonary edema. Warm extremities, wet lungs. These can also be treated with CPAP, BiPAP. Nitroglycerin can be given in this case if they're hypertensive, and furosemide can also be initiated. Your resuscitation goal is obviously to whatever the patient was coming in should be decreasing. Cold extremity and dry lungs. Here is whereby you might have a patient who is hypotensive and cold extremity. So you can give small aliquots of fluids. You can check the IVC, and when IVC is collapsing, heart is weak, you can give a small amount of fluid and see again IVC. And then you can start with your pressors. And then once the pressure is good, like it's more than 65% of the MAP, you can start dobutamine to help with the contraction. Cold extremities, which is and wet lungs. Here, you will do everything. You will do CPAP, you will give dobutamine, epinephrine or norepinephrine or nitroglycerin as well in this case, and furosemide. So this cold extremity with wet lung, you're going to treat it like escape, but also you're going to maintain the blood pressure by giving norepinephrine, and once the pressure is okay, you're going to give the vitamin. So this is how what I was explaining about is that the different categories can be treated like this. Warm extremity, dry lungs, you're only dealing with the pressure mostly, and then you can give diuretics later. If warm extremity, wet lungs, you'll have to give CPAP, nitrates, and furosemide. If cold extremity, dry lungs, you're just going to maintain the blood pressure for now. You're not going to remove fluids because the lungs are dry. Cold extremities, wet lungs, here is where you use CPAP, the vitamin, epinephrine or norepinephrine, and nitroglycerin with furosemide. So disposition. These patients are all admitted at the end of the day to HDO or ICU. Okay? At least 24 hours you can keep them there, and then once they're okay, you can dispose them to the ward. Emergency heart failure mortality risk rate. This is a risk stratification patient with acutely decompensated heart failure. And these are the criteria that you can, questions that you can ask. And the score predicted mortality in such patients over 7 days. 7-day mortality rate was 0, 0, 0.6, 1.9, and 3.9% in those at very low, or intermediate high, and very high risk respectively. So the score, the higher the score, the higher the mortality. And these are my references. Thank you for watching, and I hope you subscribe, share it with your friends, because I want to do this on a daily basis. And not only by doing this I'm learning, but I'm also teaching, which is my passion.